Good afternoon, everyone. Yes, this is giving me hard time. So, we want to say welcome to this section. This is our breakout section 1.1, and this section will focus on coordination, collaboration, and person-centered partnerships for equitable early case detection. So before we start the section, we will go through few housekeeping. So all of the meetings are being live streamed to our virtual platform and will be recorded for later viewing. Recordings will be available on demand a week after the final day of meetings. Live streams will be paused when a section breaks into smaller groups for discussion. The video will come back up for small group reports. Breakout sections do not have interpretation features. Please take a moment to note the nearest exit to you and remain calm if an evacuation is needed in case of emergency. So please stand around and look. So, like I said, this section will focus on coordination, collaboration, and person-centered partnerships for equitable early case detection, and the WHO support stakeholders collaboration. So this is what our section will focus on. So just to inform you about this section aim, we want to understand more about ways to strengthen equitable early case detection of people affected by NTDs through coordination, collaboration, partnership between the formal and informal health sectors. So at this point, I will turn over to Rossi. And sorry, I did not introduce myself. My name is Miss Hannah Berrien, and I am a research fellow on the Redress Skin Diseases Research Consortium. Sorry, Rossi.
Thanks, Hannah. Hi, my name is Rosie McCollum. I'm a researcher with the Liverpool School of Tropical Medicine, and I'm really happy to be here today. I'm standing in for Mr. Emerson Rogers, who unfortunately wasn't able to be here because of visa, but really wanted to be here today, and you'll be able to kind of hear him speaking through the video recording. So we'll have 5 different presentations today. And then at the end of the presentations, we'll have time for question and answer. So if you do have questions, please do take note of those and hold on to those questions, and we'll take those at the end after all of the presenters have had the chance to speak. After that, we'll have time for coffee break, and then we'll have some group work all together as well afterwards. So our first speaker is Emerson Rogers. Emerson works as the National Coordinator for Case Management for NTDs within Liberia. And he manages the coordination of all case management, planning, implementation, supervision, and research there. In addition to this, he also plays a really key role in the Management Committee of Redress, providing ongoing guidance and support in that role.
Hello, everyone. My name is Emerson Rogers, and I serve as the National Coordinator for Case Management of Neglected Tropical Diseases, Ministry of Health. I will be drilling you through the importance of collaboration for case detection globally. Excuse me, next slide. I will briefly carry you through the overview of what influences case detection and care seeking. What are the barriers to case detection? Who are the collaborators to enable early case detection? And how can we engage these collaborators to achieve early case detection? What influences case detection? Early case detection is known to improve both outcomes for people affected by NTDs and to enhance NTD control. We know that people who are most disadvantaged and marginalized experience the greatest health inequities, encountering barriers to seeking and using health services. In consequence, they are more likely to be diagnosed and to start treatment later, by which time they may already have a chronic condition or disability. Next slide, please. This slide shows you barriers that hindered or impede early case detection. And the first one is low knowledge and awareness of diseases and limited perception of severity of condition leads to delays in health-seeking behavior. Supernatural beliefs about the origin and causation of severe skin stigmatizing diseases are widespread. Some supernatural beliefs about the origin of the triple SDs often place unfair blame on the patient, contributing to stigma and social isolation. Patient trust and expectation in the health system is influenced by general awareness of services available, past experience with treatment seeking within a health system, and local historical context. Ability to seek care relates to having the autonomy to choose seek care and the knowledge about the options of care available. Stigma and fear of stigma can have implications for patient care seeking for an NTD and other illnesses, especially for women, with patients delaying seeking care or not disclosing their diagnosis as a consequence of fear of stigma. Indirect costs include transportation costs, feeding costs, loss of earnings, barriers to reaching specialized care. And finally, the financial impact to seek care may only be considered a necessity once disease severity increases with implications for disease progression. Next slide, please. This slide shows you the vertical approach addressing patients who are in dire need of NTDs care. Historically, we've restricted funding to specific case management NTDs like Buruli also or leprosy. Case management NTDs interventions have been ad hoc, vertical in approach, and frequently cannot reach affected persons. The global commitment to leave no one behind cannot be achieved without support to NTDs programs to identify, diagnose, and manage case management NTDs. Next slide. Integrated case management seeks to improve access and universal coverage for people with NTDs, emphasized in the WHO roadmap through community awareness, management, and integrated planning. Liberia was one of the first countries to adopt this approach. According to the WHO roadmap, one of the benefits of integrated approaches is extended coverage and early case detection. Since the initial rollout of case management, the program has sought to learn from the global literature and to engage with a range of collaborators to strengthen early case detection and care seeking. I will now provide an overview based on the global literature as well as tacit knowledge from within the Ministry of Health Liberia team, including examples that we have used within Liberia to strengthen early case detection. Next. Now, what are the activities that will lead to early case detection and knowledge of NTDs? And the first is to tackle stigma and improve health literacy and knowledge. Engages traditional and field healers, building relationship and promoting early referral. Train health workers to be able to diagnose and manage patients effectively with strong communication skills and with consistent supply chain in place. Raises awareness within the wider community about NTDs, involve both male and female community health workers for gender appropriate services. Case detection within the community for the persons affected to reduce costs and travel barriers. Who are the collaborators to improve case detection and care-seeking behavior? Next slide. This slide shows you the key actors that are involved in the patient journey from symptoms onset to diagnosis and receiving of care. To begin with, the community health workers shared information within their community about NTDs and symptoms, challenging myth and stigma to improve knowledge and understanding within their communities. Active case finding of persons affected by NTDs by community health workers through home visits during awareness campaigns can strengthen links for referral, reduce delays in reaching care seeking decisions, increase patient enrollment, and reduce permanent impairment at diagnosis. Surveillance actors, such as district surveillance officers in Liberia, carry out active case finding and surveillance into NTD programs will ensure no one is left behind. Health workers need knowledge and good communication skills to ensure patients understand their condition and future treatment. Trust in a health system can easily be lost if there are drug and supply stock out. Health workers need skills for providing holistic care given the mental health needs of people with NTDs. Next slide. Now, so with our experience with the Liberia scenario, in order to get all of the key actors involved in the patient's journey from onset of symptoms all the way to diagnosis and patient seeking care, we've managed to train persons affected, on NTDs conditions, especially involving traditional healers and field healers. And the involvement of these key actors help to reduce delay in diagnosis and facilitate earlier referral from informal providers to biomedical care. We've also managed to sensitize traditional and field healers with ongoing meetings during MOH supervision and also through the provision of formal awareness. Next slide. Persons advocates, persons affected play a very key role in promoting patient adherence to health-seeking behavior. That is, persons affected personal experience of condition and understand of community help reduce stigma and encourage health-seeking behavior. In our setting in Liberia, we've trained persons affected to lead peer support groups. They have served as persons advocate or patient ambassador to those who have the conditions and think that it is myth that are hindering them from accessing care to the health facility. So patients or persons affected have played a key role in creating awareness, in providing psychosocial support to their peer group, and also acknowledging then that there are care and treatment for people affected with NTDs. Next slide. To conclude, emphasis needs to be placed on collaboration with other stakeholders in order to achieve the WHO roadmap goal of leaving no one behind. Thank you.
So thanks to Emerson for that. Yeah, sorry that he can't be here with us today, but he is on WhatsApp, so if you do have questions, I can relay those to him and he would be happy to respond whenever we come to the question time. I'd like to invite our next speaker, Dr. Mahmoud, to come up and join us now. Dr. Mahmoud is an accomplished medical doctor with over a decade of experience in the clinical and public health field. Currently, she's serving as the National Programme Manager for Tuberculosis and Leprosy within Sierra Leone. And in this pivotal role, she oversees the development and implementation of national strategies to combat these diseases. Please do come and join us. Thanks.
Thank you and good afternoon, everybody. Okay, I'm deciding whether to sit or stand. Hi, I'm here to present on the topic or project we did, wherein we collaborated between the formal health sector and the traditional healers to reduce the delay in seeking healthcare for leprosy patients in Sierra Leone. This is going to be the outline of my presentation. Here is a map of Sierra Leone. We have 16 districts. I'm jumping the gun. This is a newer project where we did mapping of the NTDs in the country, showing high burden areas and areas with 4, 3, and 2 common NTDs. So, as a background, of course, we continue to report leprosy cases in Sierra Leone. The distribution, however, of leprosy is not quite known. However, we still find cases of childhood leprosy, and also at diagnosis, we find deformities and disabilities. So this speaks to still active community transmission. The healthcare system, as with most developing countries, is still heavily resource constrained, and it's not unique to us that people affected by leprosy typically are the poorest and most marginalized individuals. Another thing prevalent or common in our country, as for Liberia as well, I had in the last presentation, we have a lot of traditional beliefs and practices throughout the country, especially in the rural areas, where traditional healers are most often seen as the first point of call for health services. So, with that in mind, we thought that, one, we are missing a lot of cases. There's a huge risk that we're missing cases due to distance, due to stigma, due to traditional beliefs. So we decided to embark on this project so that we could gather information on reasons for delayed diagnosis, and also to use this study to impact on the building a referral system between our traditional healers and the formal health sector. So the aim of this project is this: to establish a referral system, as I mentioned, so that we can get early diagnosis, detection, and treatment of leprosy. The study was done in 11 of the 16 districts, wherein 5 were used as intervention districts and 6 as control. The study population was 140 traditional healers, that is 28 from each of the 5 districts, and leprosy patients as well, both presumptive and confirmed in both arms of the study. The duration was for 4 years. This was impacted by the COVID. So we divided into 3 phases: pre-intervention, intervention and evaluation, and dissemination. For the pre-intervention phase, we did extensive sensitization in the 5 intervention districts. During the intervention, we trained service providers, traditional healers, community health workers, persons affected by leprosy, and we introduced a logbook and a referral ticket, as well as a contact tracing form for these informal health providers. We did both quantitative and qualitative data sources. The qualitative was focus group discussions and in-depth interviews with our leprosy patients as well as stakeholders. And of course, we maintained patient confidentiality. So, to put this in context, this is how we've been doing as a country for the past 7 years on leprosy detection. Since 2017 to 2020, we've had an average of 145 cases a year. The dip in 2020, of course, is due to the impact of COVID. That was when COVID hit Sierra Leone. The study years were 2021 and 2022, implementation years, wherein we have 203 and 182 cases respectively, giving an average of 192 cases per year. So this was how we did in the 2 years. in the intervention and control districts. So there were about 57% of the cases found from the total in the intervention districts and 5% in the other districts where the study was not implemented. Childhood leprosy, we had 3% and 4% of cases per year in those 2 years, and over 60% of those was diagnosed in the intervention district. Also for grade 2 disability, we can see that the intervention district had more diagnosis of grade 2 than the control district, and all this speaks to the fact that the expertise for diagnosis of leprosy is actually a big problem. For the focus group discussions and interviews, 94 out of the 185 respondents said they haven't sought appropriate healthcare because of the lack of knowledge of signs and symptoms of leprosy. Traditional advice, low index of suspicion, barriers, access and transportation, stigma are also some of the main factors contributing to delayed healthcare seeking. Now, where did the respondents eventually seek care? 79% of them sought care from our traditional healers in the communities. For stigma, we saw from the study that stigma had a sizable impact on the health-seeking behavior, and that the delay in seeking health care, especially because of these informal service providers. So further investigation was needed to gain a complete understanding of the burden of stigma in health-seeking behavior and to inform health policy makers about the importance of stigma reduction. One quote from one of the respondents is that traditional healers are our closest health providers, and they have been helpful in our communities with reasonable cost for services. Sometimes we just need to give them gifts, and we don't have to walk long distances for healthcare services. So why not use them? So in conclusion, if you want to reduce the delay in seeking healthcare for leprosy, or the delay in diagnosis of leprosy, we need to engage with our traditional healers. A drawback of the study was that we could not undertake systematic contact tracing, and therefore we have not been able to prevent interruption of transmission, as we still have childhood cases and impairments at diagnosis. So leprosy contact tracing requires further campaigns. What did we do as a program? We established an informal contact tracing system with community health workers and persons affected by leprosy, wherein in a little under 4 months, we detected 40 cases. Also, there's been a lot of community sensitization to raise awareness on what to do when we have leprosy suspects. The next step, I think this was what I was talking about earlier, is that we've embarked on a collaboration to integrate leprosy and other skin NTDs in Sierra Leone. We've actually gone the first phase, which was January to March, but that's a different presentation altogether, to increase access to NTD services through integrated interventions. We've done the mapping, now we're doing the data integration, and then we move on to case management proper. I end by acknowledging partners, Ministry of Health, not forgetting our local partners as well. Thank you.
Thank you so much, Dr. Mahmoud, for that really interesting talk, and really interesting to hear you speak about many of the things that we've been discussing in our study in redress. And just to maybe kind of add to that and speak more to some of those issues, I'd like to invite Hannah Berrien, to come and to speak about that. Hannah is a research fellow with Redress, and she's been working on Redress since it started, so for the last 4 years. She specifically works a lot on the patient engagement and person-centered approaches thematic area. And she also has a special interest on collaborating with traditional and faith healers.
Thank you, Rosie. So, my name is Hannah Berrien, and this presentation is on behalf of the Redress program. So, for the introduction, we know that persons affected by skin NTDs experience stigma, mental health condition, and also they have beliefs to seek care from other informal health providers, or both the formal health providers and the informal health providers. And sometimes they have delay, and that delay has to do with seeking biomedical care, which may result into physical disability. And the informal health providers, they are working in the different communities, playing different roles to support people affected by NTDs. So at this point, we have limited evidence to identify suitable structures for collaboration between the formal health providers and the informal health providers. So for the objectives, with us in Redress, we aim to use a person-centered approach to evaluate, develop, and adapt health systems interventions for the management of skin NTDs. So we seek to investigate the role of informal health providers when it comes to managing people affected by skin NTDs. We also seek to understand the experience and perceptions of the informal health providers caring for people affected by skin NTDs. And we will co-design intervention to improve the engagement of informal health providers through the use of participatory approaches. So within Redress, during our formative phase research, we use series of participatory research approaches. For example, we use photo voice. That was done with the informal health providers. And after our formative phase data collection, we disseminated our results to the county. We also developed tools for the informal health providers, and we did a sense check with them. With the tools that we developed, we trained them, and we roll out our intervention to those informal health providers. So as part of the methods we use, like I said earlier, we did focus group discussion with the informal health providers. We also trained them. We did focus group discussion after the training. We also conducted reflective diary where the informal health providers had a reflection on their engagement with people affected by skin NTDs. And we conducted key informant interview with the health workers to understand their engagement with informal health providers. So for our results, we will present this result into two folds. One is the perception about skin NTDs for the informal health providers before the training and after the training. So before the training, informal health providers had feelings of empathy towards people affected by skin NTDs. And they also reported stigma as a reason for people affected to conceal conditions. And they describe multiple prolonged approaches to addressing stigma. And they placed emphasis on trying to dispel myth that stigma related to a specific condition at the community level. They referred patients, they provided counseling, and also they have a desire to collaborate with the informal, to collaborate with the formal health system. So as part of the roles, the informal health providers, They are providing. They providing physical support, like being able to clean a wound of patients with COR-NTDs. They also providing spiritual support, like prayer. They also providing mental health support, counseling, and social support, like providing soap to persons affected. So this is a result after the training. So persons affected mentioned that there's a need for a traditional healer mentioned that there's a need for persons affected to visit a health facility, and also there's a need to avoid stigmatizing those persons affected, and they are now raising awareness in a different community. And many faith healers also express the desire to comfort and support people affected and sharing hope in God. So these are some of the challenges that we experience. Some participants describe mixed experience with the health workers' attitude to those patients, and the health workers can get upset with traditional healers if they keep the patient for a longer time and not taking them to the hospital. And some of the traditional healers felt that they had no relationship with the CHA nor the CHV, and minority of the faith healers also refuse to refer patients due to perceived spiritual responsibility to care for the patient, and the informal health providers survive on their income they earn from treating patients. So this can create challenge to refer the patient because it is a means of survival for them. So as a take-home message, there is willingness of the informal health providers to collaborate with the formal health system to support the care for people affected by NTDs, including the delivery of stigma reduction strategies and mental health support. While the traditional and the faith healers also play a key role in supporting and addressing stigma, and sensitization section for informal health providers can address myth and misunderstanding with the potential to reduce stigma and inform referral. So there's a need to combating NTDs require multi-sectoral collaboration between the informal health system and the formal health system. So this is a link to redress intervention manual. So at this point, we want to say thank you to our funders, our collaborating partners, and affiliated partners. Thank you.
Thanks, Hannah, for speaking more about that particular issue. Really interesting. I'd like to now invite Tia to come and join us. Tia is the Senior Program Manager for Health Systems at the American Leprosy Mission. And in her role there, Tia has supported ministries of health in Liberia, Cameroon, Nigeria, and Sierra Leone to develop, implement, and evaluate policies to improve integrated case management interventions for NTDs. Thanks, Tia.
Thank you, Rosie. I've already been introduced. As she said, I'm Tia. For most of my name is Tia Wanlin, but Tia is parenthesized there because that's what most people are able to say. And for people who know me as Tia, it's probably the first time they're actually saying my full name. So a little background. We're all here because we all want the same thing when it comes to NTDs. We want to make sure that everyone, everywhere, able to have access to care that is affordable. That is also in global policies like the Sustainable Development Goal 3 to ensure health and well-being for all. And the end goal of that is to leave no one behind. By the very word neglected tropical diseases, we know people are already being left behind. So how do we achieve this? How do we not leave anyone behind? And in the WHO 2021 to 2030 roadmap, there are some key things that have been identified to prevent, control, eliminate, eradicate NTDs, as we all know, by 2030. Partnerships across various sectors, mainstreaming NTDs, government ownership. I like to say that one because it's a complicated one. And in order to do that, we have to move from measuring our process. So oftentimes we train 30 health workers. Well, that's great. what has become of them? How many patients were treated based on those 30 health workers? How many patients have been managed? How many have been healed? So we need to start focusing on measuring our impact. We need to also get away from the vertical programming. So oftentimes in many of our countries, especially in the Global South, we have trachoma program. We'll have multiple disease-specific programming. And with a field like this that we are called neglected tropical diseases with very minimum resources, that's not a very effective way to ensure that we actually leave no one behind. So looking at more holistic approaches, partnerships, collaborations, and integration. And we also need to get away from the donor-driven funding, right? Because a lot of the times that comes with a lot of prioritization on what is important and agenda, you know. And so having more country-based ownership, and that's beyond just the financial resource, but also country really feeling a part of and being a part of the planning and implementation and decision-making when it comes to our NTD interventions. So Liberia, you've already heard from our wonderful NTD case management coordinator, Emerson. So I won't go into details, but Liberia would like to brag that we were one of the first countries to do this integration thing, and I love it. I say it all the time. I say it to my Sierra Leonean colleagues that Liberia did it. But yeah, so in 2016, Liberia was able to develop the first strategic plan for integrated case management of NTDs, and based on that, there were a pilot done for a couple of years in 5 out of our 15 counties. And there were a lot of success in terms of early case, well, not necessarily early, but case detection, because nothing had happened for a long time. So the cases that were detected initially were at the later stage. But it did bring up a lot of issues and a lot of positive results as well. And so the redress project came about from that, and redress expanded on that, focusing on the person-centered approach, because with the integrated case management being piloted, it was mostly focusing just on the health system and trying to integrate the diseases. At the time, it was only 2 programs anyway, so it wasn't as complicated. But redress, focus on looking at holistic care for the person. So what affects them? If it's mental health, how can we integrate that, and all of those things. And so you already heard redress was done in 5 phases, and the evidence, the picture on the right there, I guess is my right, is a young lady in Liberia during our supervision. She came into the health facility, was not in school, and she was suspected of having BU. So this is the theory of change with redress over the 5 phases, from the formative to the evaluation and dissemination. The idea is that there will be impacts at the community level, especially for stigma reduction, at a national level to inform policies and strengthen the health system, and at global levels as well. So these are, Hannah talked briefly about the methodologies that were used. Photo voice was one of my favorite, was very impactful, I think, for patients and traditional healers and people at the community level to be able to communicate their emotions and feelings and thoughts about what was happening around them and within them as well. So in order for us to achieve this, leaving no one behind, we have to do that through the health system. I don't see any other way around it. And looking at the findings from the formative phase of the redress project, using the 6 building blocks of health system strengthening, the findings show that in terms of leadership and governance, there were poor collaboration within the health system. So NTDs have come to the level where NTDs were integrated into one program. However, NTDs was not necessarily integrated or mainstreamed well into the health system. And then also it was a top-down method a lot of the times to the planning, so things were done at the national level, and then the implementers at the community level had to do that. And so there were not much involvement of persons affected and those who are actually on the ground when it comes to planning. Service delivery also realized that there are a lot of stigma faced by patients, and that oftentimes, as we've already heard, that the first point of care are those in the community, whether it's a spiritual healer, faith healer, or a traditional healer. People run to those that they were most comfortable with first. And in terms of the health system financing already, there are a lot of issues in terms of commodities for NTDs, because it's not as funded as other programs, funded by Global Fund, so there were always shortage of something. The health workforce, the health workers were limited, since this was only piloted in few counties. So there are a lot of health workers not able to even diagnose NTDs, let alone to diagnose mental health conditions affecting patients that had NTDs. And then, as I said, there were frequent stock out of drugs and supply when it comes to medical products. And then for the health information system, although NTDs, for case management, NTDs have been integrated into the DHIS2, but it was specifically for BU, leprosy, some part of LF morbidities, but a lot of it too, there was still a lot of issues in terms of having a strong data system. And so what did redress do about that? For the intervention, redress ensured that during the planning phases, from the proposal development even to the planning of the formative phase and the intervention, there were stakeholders included at all levels, so from the community level to the patients to health workers, everyone who will have anything to do with implementing the interventions were included. And then for the governance part, there were advisory boards at the county level, and that was like a 15-member board that included people from so gender, education, different sectors at that county level. And then at the national level, the Ministry of Health level, there was a ministry advisory board, and that included different disease programs within the Ministry of Health as well. And not only disease programs, you have supply chain and data and all of that. And for the service delivery, there were peer support groups, as has been mentioned, peer advocates and patients affected coming together and advocating on behalf of other patients as well. And you have mental health screening, so health workers were trained to be able to look for those, identify those signs of mental health conditions in patients. And so that was also another good one. And then for financing, you had, so to incentivize these community health workers, right, because we know they all have other things to do as well. And we expect community health workers to be completely volunteers, but considering the situation, it's almost impossible to do that. And so, but also providing finances to them and providing cash sometimes is not sustainable for the government as well. With Liberia having well over 9,000 of them, there's no way. And so instead of giving them cash, there were systems put in place, like maybe during a meeting, give them an award for being the best community health worker for that month, or bringing the most number of cases, suspected cases and what have you. And that really was very motivating for a lot of them. And then, of course, providing logistics for supervision activities. And we have for the health workforce, as I said, health workers were trained. They were trained on mental health and NTDs and community health, because they had to supervise community health workers as well. And we trained traditional healers and faith healers to support, one, in case detection, two, referral, but also to provide the counseling and just emotional, psychosocial support that patients may need along the way. And there were prepositioning of medications. So prior to that, drugs would be at Ministry of Health, for example, and a patient is diagnosed of leprosy or BU, and then it's some delay in starting treatment because they have to ask for those drugs to come from Monrovia, whereas during redress, those drugs were positioned closer to them that they could easily access it for treatment. And then for the DHIS2, the health information part, there were more indicators added to the NTDs, so mental health was not in the DHIS2. So it's been a good collaboration, because mental health has been able to pick it back up for NTDs as well. The neglected is pulling the neglected. And so that was very helpful. So we now have mental health indicators into the DHIS2 as well as ONCO and some of the other NTDs as well. And so what did we learn? So in terms of universal health coverage and leaving no one behind, in redress we learned, one, the participation of person affected is very important, because they know what's happening, they know what they need, and their voices should be heard, because it does help to dispel some of the myths in the community when we talk about stigma. So one of the things with the myths is that a lot of times they will say, this is witchcraft seed, this is a curse, that means it's never going to be healed, it's never going away. So when you have these patients are able to come back from being treated and say, yes, I have BU, remember I had that ulcer on my leg, and now it's gone. And that in itself is a testimony, and it helps promotes positive health-seeking behaviors, because some other patients may be afraid to go to the health facility thinking there's no hope, and once they see that, they have courage to do that. And then integration across disease programs. So not only across the disease programs, but also into the health system is very important, because that also improves the capacity of the health system to be able to really care for these patients. And instead of having a health worker, like now health workers have been trained on NTDs and mental health. So instead of just looking for NTDs, they can also diagnose other mental health conditions, and that also, increases the coverage as well. And then the formal and informal sector, that collaboration is also very important, because it also promotes awareness and also helps in terms of early case detection, because as we said, that's the first point of contact and care for a lot of patients. So if they're a part of it and there's a collaboration where they're able to refer patients, then we can reduce any cause for disability. And then the multidisciplinary advisory board too was very helpful, because especially at the county level, having multiple stakeholders from different sectors, they also help prioritize NTDs and give a visibility to the NTDs, that NTDs is put on national and local agenda as well. And final thoughts. So there are still some issues, especially in terms of data, when it comes to strengthen the health system in Liberia for NTDs. But that, however, is not limited to NTDs. It's a system issues in terms of getting the data from the health facility, the accurate data from the health facility to the system. And then cross-departmental and sectoral collaboration is essential to promote sustainability as well, and ownership and what have you. And definitely, if we don't want to leave anyone behind, and we surely want to move from neglected to eliminated, we have to collaborate and do everything together from the onset, and bring everyone on board to make sure that we move from neglected to eliminated. Thank you.
Thank you so much, Tia, just for giving us such a really helpful kind of health systems perspective. I think that's really valuable and really helpful. So our next presenter, again, it's a pre-recording. Unfortunately, our next presenter can't be with us, but our next speaker. But his name is Emmanuel Zeze. He'll introduce himself a little bit further in the recording. But just to give you a little bit of background, Emmanuel is a person affected and has previously had Buruli ulcer and received treatment and completed his treatment for that in 2019. Emmanuel encountered quite a lot of delays in his health-seeking journey. He'll speak a little bit more about that in the recording. But Emmanuel really has played a really key and really critical role within Redress, advising us in a lot of our work and what we do around community engagement. He's a co-researcher within Redress and has been involved in much of the work that Tia and Hannah have spoken about today. He also sits as a co-chair for the Community Advisory Board that Tia introduced, and also helps with the setup of some of the peer support groups.
Hello, everyone. I'm Emmanuel Zeze from Liberia. Let me use this time to tell the Almighty God thanks for affording me the opportunity today to be part of this COR-NTDs in the world. And I'm grateful to Almighty God to reach this project at this level of reaching persons affected. I am Zeze. I was affected with NTDs a few years ago, and I've been going from area to area for treatment until lately I came to the facility where the NTD focal person took my specimen and carried to Morovia for a view. And later, when they brought it, I was confirmed with Buruli ulcer, and then I started treatment with the ORCs at the Bakame facility until early 2020, and I was recruited by Redress. Went through an interview where I was chosen as persons affected to collect data, where we were trained in the formative phase to do photo voice, group discussions, do a body mapping, and from the formative phase, there are a lot of things that we learn, especially as a persons affected, that which of course was very much encouraging to me. And from there, I served as a co-researcher on the project, on the Redress project, and later I was elected as a co-chair for the Community Advisory Board in Lofa County, and later during the intervention of the Redress project, I was also selected as the chair for the Community Advisory Board in the 3 counties, and also the head for the peer support group in the 3 counties and the 6 districts in the 3 counties that the Redress project is in. So power mean to me, the meaning of power to me is a good idea, because being a person affected, having the knowledge and training to be able to do tasks, example, to collect data as co-researcher, to be able to identify and refer someone with possible NTDs, and being able to share experience together with others, including other persons affected in the community, and being able to earn money, being able to raise and get involved with activities in the same community that have previously experienced stigma and discrimination, being able to carry on awareness activities through community meetings and, and radio awareness, and being able to help others, people affected by NTDs, to get care. And so these are my involvement, and I do patient survey. I also do health worker survey, where I opportune as a person affected to meet with health workers within my county or in my districts, where I was opportune to visit the 13 health facilities that were assigned to as a co-researchers, to do patient survey and to do health worker survey and to do health ledger survey as well. And also the idea of putting members together, calling ourselves a peer support group, and having the putting in recommendations for sustainability wherein it were approved. This is how our memberships are like 15 to 20 persons, and we group ourselves, and we are the peer support group for our group, and these are our members. So, why is power important to me, to persons affected? When persons affected by a skin entities had experienced stigma and discriminations for many years, powers is important. It can it can affect all areas of their life. For example, a person affected may not have knowledge to understand their condition. A person affected may not have been able to complete school due to their condition. Sometimes the, the partner of a person affected may abandon them due to their conditions. Especially our persons affected with these conditions, I have similar story where my partner had to leave me because of my condition, that I was in bed. All of a sudden, when she saw my wound, she burst out with tears and she had to quit the relationship. So sometimes the community do not go around to visit persons affected due to their conditions. So when loss of power has helped choose stigma and discrimination, it is important to change the situation too. Perhaps could be long-term training. If persons affected could be given opportunity to take a long-term training where they can partly diagnose conditions, be it involved into health working system, perhaps could be trained to the higher level to serve as an ORC or even a CHSS or a second trainer or a registrar or even a dispenser. So taking part in taking part in a support group with other people affected to share experience about challenge and changes, opportunity to break down stigma, example, making making and selling soap. All of these things help to break stigma. The essence of selling a soap is your conditions. You are not limited to only selling soap. But because of your condition, perhaps you got Brady also, or you got leprosy, or you got yours, all of these things on your skin, there's it's not possible to sell rest or food kind. So you have to sell something that is not eatable, something that somebody can purchase, perhaps use it on their body, but it's not consumable. So you choose to sell soap because you sell the soap, somebody buys soap and go and wash. And in that direction, such stigma is already is a kind of a breaking because there have been belief in the community. This man got beat, so he got leprosy, he got hydroxy, he got yours. He doesn't have any power to do anything. So people who have the belief that they will not come around you when in the process of selling soap, that breaks the stigma. People come to come around you. People come around you to buy soap. But who say they can come around? They come around. They do other interactions. Become the float with persons affected with the conditions of Brody also or leprosy. So opportunity to break down in stigma example, the selling of soap, to raise awareness and to have opportunities to attend program or staff meetings to be introduced to hierarchies of NGOs in the country or in on the globe. Uh, that is it is an idea or it can help to change power for persons affected and opportunity to meet with NTD program staff to share experience and advocate and share advices. So in the process of meeting with the staff or attending meetings of such where you met up with staff and you have been opportune to share your stories, all of these things helps to break stigma around NTDs. And also opportunity to do radio campaign and attend international conferences, increase trust from community. If you attended a international conference where you are opportune to meet with more than 10 NGOs that is working around entities, that could help. It could help to break stigma and also taking pictures with some of the attendees for the conference and having been opportune to meet with hierarchies from the biggest organization of health, which is the WHO, the World Health Organizations, having some conversations, taking some photos, and sharing in a community that you came back to. That will help. It will also build trust between you and the new patients that have just surfaced within the NTD's terrain. That will create trust. It will make them to explain their story and also share their secret with you. Secrets that have been healing. It will help to express, they will share their secrets with you. So what difference does involving person affected make to entities programming? It's a big difference. It helps to increase trust between community and health workers and health system. If people affected by a similar condition see someone with the same condition, see their wound, and hear their story of recovery, then they are more encouraged to also seek care. Person affected can help NTD staff. Example, if patient does not want to go to health facility or want to stop treatment, or the NTD focal persons calls me and we go to meet with that persons and encourage them to go to the health facility. So because of the relationship that have been built between you and the hierarchies of the health system, that is the NTD focal persons. So in some cases, you go somewhere, you call the NTD focal person, you say, I'm here with Mr. X, I'm here with Zeze, I'm here with John, he's affected with a condition, but I'm here to tell him a story. But I want you to come and back me up to tell him if what I'm saying, if he will believe it or not. And then definitely if the person come and introduce themselves perhaps with article with identity from the Ministry of Health in their positions, definitely that secrets come out from the patients that the persons affected may have gone to talk to them. So it helps to change stigma and discrimination within the communities. So how can person affected be involved with community engagement? Person affected can be involved with the activities in the community, perhaps on the leadership of the community, and also being used, being well capacity built with a long term training, just what I said, and also meeting with other persons affected, sharing their life story, giving their conditions, meet together with other persons affected to encourage them to seek care at the health facility, and also in collaboration with focal person and through referral form and other members of the local community advisory board that we should compress and we all will work together. If somebody from the community advisory board knows I'm a person affected on the board, the person saw somebody with a condition and they were announced that I'm the person affected, I'm the head for the peer support group. We are controlling 15 to 20% in our district or in our town. So definitely that is a message that go across from the community advisory board group, and they will call you. See, we met one or two persons with this condition. We want you to come and explain your story to them because we have filled on them to go for treatment. But we think being part of the community advisory board and being a person affected, I think if you come and explain your story to them, it will serve as a yardstick to them to go for treatment and to change their mind of belief. And often people trust me because of my story that I explained to them. And also some CHA and CHSS that rapport has been paid, they call me. And we also do community awareness where we go to the market ground with been opportune to have photos of persons affected, sharing images and going from area to area, and also our group where we go we have challenges of data. So you have somebody to interpret what you say so that can, and the persons affected will be the one with the placard in their hand with the photos explaining to them where they came from, this are condition, and also using the radio because there are some areas that you'll not be opportune perhaps due to some challenges in mobility or because of road. So you could use the road, the airway as a person affected to explain to. So raising awareness and advocating for persons affected globally. If persons affected have been opportune to attend conferences where he or she recommend her his or her group that they are controlling, especially within their country or their localities, and meet with other persons affected in conferences that persons affected attend. That is another good way and is a way of raising awareness and advocating for persons affected. Because if you attend those kind of a conference, things that you see other NGOs network can do within their areas, and then you learn from them and bring the idea to your areas so that you can work to make a change, and also you can work to eliminate NTDs globally. And also paper writing. So my recommendations for the future in community engagement involving persons affected by NTDs, NTD programming to include persons affected as part of their outreach and awareness raising activities, NTD research studies to involve persons affected as co-researchers, international conferences to invite persons affected to take part and share our experiences, empower persons affected with long-term training, perhaps to be able to identify and diagnose NTDs, opinions, opinions of people with NTDs to be prioritized in decisions making, and also government recommendations from government to health facilities, and also recommendations from government to persons affected associations or persons affected group in the country or in their various communities where they are. And I want to take this time to appreciate all of the partners with redress. Thanks for prioritizing persons affected. Thanks for the support. Thanks for the sponsorship. It is our prayer that this should be a caveat to all NGOs network around entities to prioritize persons affected so that we can have to eliminate entities around the world and to change neglected tropical disease to another name. Could be a success disease, or could be a name change. But instead neglected could be changed. So a big thanks to all of my partners, the Equitable, the Liverpool School of Tropical Medicine, and the Carter Center, and also the Pacific Institute and the UL Pio, and also a great thanks to Redress for taking a bold step using persons affected in these capacities of entities activities. Thanks.
Great. Thanks so much to Emmanuel for sharing his experiences with us and his reflections really about the role of that he plays within redress, and the role of patient advocates within research studies. I think really valuable, and really just for me a reflection I think that has come from all of our presentations is really, I suppose, the importance of trust. I think Emmanuel spoke a lot about the importance of trust that people place in him as a person affected, and I think it came through in some of the other speakers' presentations as well, that importance of trust in the kind of care-seeking relationship where people go to first. For the speakers, I don't know if you're happy to come up to the front, I suppose, just to take any questions that we have. For everybody else, if you can prepare your questions for our speakers, just that would be lovely. One more chair. Great. So, sorry, I'll get out of the way. Okay, lovely. So, yeah, does anyone have any questions to start us off?
I think I have a very basic question. We are talking about case detection or early case detection. What is the case definition? Has a person who has microfilariae in the skin but no skin disease, is this a case? This is an early case, I would say, but that's not the case you are talking of. Is a person who has microfilariae in the skin but has pruritus after the mass drug administration, is this a case? So what is your case description, or definition? I think would be really helpful.
Thanks. Just wondering who would like to take that question.
You're throwing that in my. Okay, so I think for us specifically in Liberia, I think when we talk about case, especially when it comes to case detection, is those that can be identified. So the manifestation on the skin that the community health worker is able to see and suspect.
Thanks, Tia. Happy? Okay. Yes, sorry, I'll just come over to you.
Yes, thank you so much, all of you, and congratulations. What I celebrate especially is the involvement of persons affected by NTDs. I had the privilege of meeting Emmanuel in Tanzania a few weeks ago, and I was chatting with him, and I was sending him pictures and congratulating him on the presentation. And my question is, because I come from the leprosy field where we've had this involvement for a number of years, but my question is something that I sometimes hear and sometimes I perceive that the question is in the room. How do you, if you don't have a network of persons affected, if they're not organized, what are some things that you might have learned about starting that involvement from zero? If you will.
Thank you so much for the question. And I think Emmanuel was really happy to get your messages. He was letting me know, so thanks. Who would like to take this one?
I can attempt to answer that. So my country already has an existing association of persons affected by leprosy. But they recently registered this year. So I would say for our context, usually I worked in the hospital setting for a long time. These leprosy patients don't usually have communities to go back to because of stigma, because of the duration of their stay in hospital due to wound care and things like that. So we start there. You do have a few patients who tend to come in quite regularly due to complications. They're not active leprosy anymore, but due to complications, they tend to come in regularly into the facilities. And this is where the association was born. So they used to have their meetings in the wards. Other people that were admitted before came to visit, and they start discussions there. And we helped them in this year to register as a formal NGO. So I think that's where it starts. With leprosy, you don't treat and they just go away, unfortunately. If the disability or the nerve damage is there, they usually come back to hospital with complications. So we start from there. Thanks.
Thanks so much. Yeah. Sorry, I think I saw you first.
Thank you. So I was very interested in your comments about traditional healers. So I was part of a consortium that was trying to develop a test for Buruli ulcer, which was then evaluated in Côte d'Ivoire and Cameroon in the field. The lesions that came back from the field evaluations were actually quite scary to look at. But to your point, pretty much all of them had already been treated by local healers. So I can see what a local healer can do for you. He can guide you to the people who may have a relevant skin disease. But can you please elaborate on the psychology of the healers? So what is in it for them, right? Are they losing power or credibility? Are they not just, in a way, giving their business to somebody else?
Thank you.
So it's a difficult thing to say. So most of the traditional healers, they are indeed receiving patients, and they also want to refer patients to the health facility. But the dilemma is that is where they get their food and also survivor. So indeed that we train it and we keep talking to them to refer patient, but they keep telling us, yes, we'll be able to refer patient, but how do we eat? So we keep doing awareness and keep talking. We know that it will end, but it's a gradual process as we keep doing awareness as we go on.
Thank you. And for Sierra Leone, yes, it's a similar situation. They are known to be healers. So now referring patients to the formal health sector is unheard of. But that was one of the good things that came from our Ebola outbreak, was that traditional healers were then gotten on board the formal health, well, they're being consulted. So now there's some form of collaboration established already. For our project, it was a smaller project. So what we did was, for every confirmed leprosy case, you get something as a traditional healer. Less than $1, really, but just something to encourage referrals. The sustainability of that is another question altogether. I will not go into. But for the projects, that was what we did to encourage that. Thanks.
Thank you. Was there another question here?
Thank you for all the presentations. They were really nice and interesting. I was hoping that one of the speakers could explain a bit more about how you evaluated or measured the impact on equity in your projects.
Thank you. Just wondering who would like this one. Tia?
No, not that one. Laura, one of you want to speak to that?
Hi everyone, I'm Laura. I'm from the Liverpool School and work with the Redress team. In Redress, the way we've looked at equity is in different ways. So from the very beginning of the project, making sure the right people were behind the around the table and understanding what equity meant to them as well. But kind of empirically, with the quantitative side of things, all our data analysis is disaggregated by things like gender, age, geographic location of where cases are identified. And then qualitatively, we use different gender analysis frameworks, particularly intersectionality and other things when we're looking at and considering the data. And then also working with a national program for them to try and understand how to build equity indicators into their national plan. While I've got the microphone, I just wanted to add something in relation to your question. One of the things that we've found in many different countries when working with traditional healers and how to continue their role and engagement, often people affected, I think, that we've worked with compartmentalize their illness as well into kind of biomedical illness and spiritual illness. And so one of the things that we've tried to think about a bit more in Redress is what can traditional healers or faith healers continue to do alongside the biomedical intervention that we maybe think about as essential. And so trying to work with them to train them on kind of basic psychological support and encouraging the formal health system to refer back to traditional and faith healers where that ongoing, more holistic care might be necessary as well. But we're still analysing to see how that's worked out.
Thanks, Laura. Great. Any last questions? Was there another one? Yeah.
Yeah, really enjoyed the talks. Thank you very much. So I work in the areas in the Pacific, and one of the issues that we have with trying to integrate the programs, I think someone talked about integration and getting advisory boards, is actually persuading the government not to keep on changing the staff. So the nurse keeps on moving, you know, into the next thing, and so you keep on losing expertise. Got any comments on your really advocating upwards and from your advisory groups perhaps to try and get around some of these issues?
Thank you.
Well, in terms of you know, the government changing staff and staff retention, that's a whole another topic. So these advisory boards are not necessarily, the comprised of different groups of people, not necessarily the clinicians alone, because those are the ones that usually go. So this would be like, this could be like a gender lead in the county, for example, mental health lead in the county, or a WASH lead in the county. So those are not people that are easily moved around compared to the clinicians. So that has not been much of a concern. But what they do provide is that visibility, because those are the decision makers in the counties, and they also help prioritize NTDs within the county planning as well, at the local government and national government area.
Thanks, Tia. Any last questions? Oh, yep, sure. Thank you.
Tia, I think it was you who talked about incorporating the mental health indicators into the NTD or into the register in the DHIS2 system, and I was just wondering if it was affiliated with the NTD indicators and questions, or was it a separate module or unit entirely, and if you were able to do any data analysis to see the relationship between the mental health indicators and the NTD indicators. Thanks.
Laura's going to finish on this one, but I will start. Yeah, so in the DHIS2 platform, since the training was integrated training with both mental health and NTDs, it's just basic psychosocial NTD support. So the indicators are integrated, and so it's for NTD specifically. It's not just for all mental health conditions. So they are, as they are in the integrated manual. As far as the results and analysis coming from that, that is still ongoing, but I think Laura may have more information on that, if at all.
People with NTDs, and then obviously there's another separate mental health module as well. So the idea is that people would record side by side, and then in terms of the analysis, it's done at the national level. If Emerson was here, he would be able to talk a bit more about that, and also the complicated process that they've had to go through in terms of getting different sections of the DHSI2 to talk to each other as well. And improve health literacy to encourage people to come forwards without the need for financial incentives. We talked about skin camps being useful in breaking down stigma, expert patients being helpful in modelling change, and also ideas around non-cash incentives. And then finally, we were also talking a lot about case definitions. We've talked a lot today around symptomatic case detection, but also thinking about asymptomatic case detection as well. In terms of questions, we talked about thinking around what are the most appropriate case definitions for traditional or faith healers. Maybe they may have different case definitions that don't draw on biomedical framings, but maybe mean the same thing. Motivating factors or best strategies to convince traditional or faith healers to be involved in case detection, but also thinking about how the health system can better include traditional and faith healers. For community health workers, we thought it was important to think about how the gender of community health workers or person doing case detection may change who is found, and what are the different strategies we need to identify cases for people of differing genders. We talked a bit about how, when we're thinking about operational research, we select where we do research and what that means for health equity. Often we pick areas that are easy to get to or where research is done before, and what does that mean? We talked about, from a public health perspective, thinking around the feasibility of testing for multiple conditions at once, and thinking about how we can mesh surveys for NTDs with other programs. We talked about a need to think about equity and how that plays into case detection, and then also how we can think about retaining or motivating staff and what we can learn from the broader health systems literature around that. And then finally, with 1 minute to go, we began a discussion on how colonial legacies can influence trust in programs and case detection activities. And I think that's really important in thinking about how people have maybe been treated in the past and why they no longer want to engage with the health system. Did I miss anything? No? Okay.
Thank you so much, Group 1, for that feedback. Group 2, any representative? Thank you, Rosie.
Sorry. So for Group 2, in terms of the first question, there's lots of really interesting discussion and sharing of experiences from within the group of examples in different settings of different avenues for case detection. So there were more examples of ways where traditional healers had been engaged, and reflection on the importance of status and of recognition within the community for different informal providers, with examples having been given that in some settings they've maybe been given a certificate or something instead of financial remuneration. There was also reflections and discussions from settings in South America, where we chatted about the role of patient advocates and kind of how they can really play a really influential role in how they maybe meet with, spend time with a newly diagnosed patient, with their family, and the importance of that, as well as kind of those discussions within the wider community and things like that, and also how they can play a role in identifying other persons affected. So there was an example of a mechanic who kind of was able to kind of, in the course of his work, able to kind of identify and refer someone else. Then we also had examples of how that has kind of been formalized into networks in other settings. So there's like national federations where people now have opportunity for kind of training and certificates as part of their role as patient advocates, and kind of the importance of that role in case detection. Then we also had examples of case detection relating to MDA campaigns, and the role of volunteers, perhaps moving house to house as part of that. And then we also had a bit of discussion as well about how to identify at preclinical stage, and role of testing within that, and kind of a conversation around that, and as well around what might work in one setting might not work in a different setting, depending on the context and availability of testing. Then we also had examples, some interesting examples of how schools can perhaps play a role as well in strengthening case detection. There was examples within, I think Brazil it was, where there was like children were educated about leprosy, and then they had a homework to kind of go home and explain it to their family, and that was an avenue for strengthening case detection as well. As well as similar to the last group discussion about theatre. In terms of research questions, questions that came up for us were big ones relating to incentives and remuneration for traditional healers, faith healers, and also for persons affected, and what is best and also sustainable relating to that. Then there's also a conversation about how can we have meaningful data for NTDs at community level, working within different perhaps structures that are maybe being rolled out. And with the example within Kenya, that there's new opportunity to kind of work within community health systems to strengthen that. We had some discussion around how you can have mutually beneficial relationships between informal providers and the health system, so that it's beneficial for all groups, and what does that look like in practice in different settings. Other things that we had was how to refocus perhaps informal providers to have a role in providing perhaps listening support rather than them perhaps intervening themselves, and what that might look like. And again, sort of to what extent can these kind of influential traditional or faith healers be a voice for addressing stigma. And then another point around kind of unpacking power and trust, and how does power determine how to engage with these different actors. Lastly then, we kind of chatted a bit in terms of integration. For new partnerships, we spoke about kind of the role of integration within kind of community health information systems. We spoke a bit about kind of schools and exploring those networks. I think that's us. Unless the group has anything else to add.
Thank you, Rossi. Thank you so much. You're on time. Group 3? No. I have the master copy, Group 3. Tia.
We followed all the instructions and we have our beautiful sticky notes. I'm going to stay here and read them. But a lot of things we talked about are already similar to what has already been presented, so I'm just going to focus on what we did not cover. And the question I was asked around fit healers and traditional healers and how do we work with them, that's talked with us, so a lot of our discussions was around that. For the first question on our experiences and ideas for strengthening case detection, it was quite interesting. A lot of the comments had to do with campaigning, doing awareness campaigns, gain camps, which was already mentioned. We also talk about the differences in the different countries. That is not one size fits all. So it was interesting to hear from my colleague. Oh, he's no longer here, but he was here. Oh, there he is. Okay, I was like, he's gone. That what works for us in Liberia with the traditional healers and all of that was not so successful for them in Bangladesh. That they find it most successful using family members of confirmed cases to do contact tracing using some technology as well. And so that was really interesting. So for number 2, the operational research questions, we had quite interesting ones, but a lot of it was around, we're all just very curious, how do we solve this traditional healer situation? Do we incentivize? Do we not? If we incentivize, does that help? How do we reduce the burden of work that we place on community health workers? Is this where traditional healers would be helpful? Talking about the health system as well. And so some of the questions we had was, how to engage traditional healers in patient care, to what extent collaboration between the health staff and traditional healers reduce mental health consequences for NTDs patients. And so a lot of our thoughts were around, what do we do to ensure that traditional healers are truly a part of the health system and that value grows and not diminishes, that they actually see themselves as collaborators and colleagues of health workers and not just feeding them patients and then go back to their communities. And then for new partnerships, we thought about it from the perspective of a patient and those at a community level that really have impact into awareness and influence in the community, that their voices should be heard. So we talked about including, in Liberia, I said, for example, we have the Community Health Council, which is the link between the community health workers and the health facility. So integrating those people into case detection. We also talked about collaborating with teachers and schools, drama and clubs and other things in the community. We talk about marketeers, marketing association, women groups in the community, youth groups, and what have you. So that was our discussions. Thank you.
You left 3 minutes. Thank you so much, Group 3. Group 4? Yes, I will do that.
Okay, so I'm going to start with 1, and then I'm going to pass on for 2 and 3. In terms of sharing experiences, our group mostly had experiences in leprosy and LF, and we kind of talked about how community engagement is limited by stigma. That formed a lot of our discussions, and a lack of benefit to the people who are engaging with the case finding. Meaning particularly with things like LF, if no morbidity management is offered, all you're doing is case finding, you're not providing any treatment or any support, then there's kind of ethical considerations, but also there's no incentive for people to engage. We talked a bit about contact tracing, but how the efficacy and impact of this is unclear for diseases like leprosy. And we talked a bit about incentivizing case finding and how this can help, but it's not necessarily sustainable in the longer term. And it's not necessarily very effective. Like, if you get money for me reporting my stigmatized condition, then how does that incentivize me to engage? And then in terms of ideas, we talked about things like investing in morbidity management to boost detection, so to increase community buy-in, having something along the lines of like a multimedia campaign with anonymous reporting so that you don't have that kind of stigma element, and that could be followed by local follow-up if you had kind of a spatial link to that reporting. And we also talked about the potential for combining contact tracing with education to try and enhance the engagement and reducing the stigma.
Just continuing on the questions from what Emma said, these are some of the research questions that we thought that we will write down. What is the added value of enhanced contact tracing in leprosy, and how the type and duration of the contact can actually influence case finding? To what extent can we use new digital tech multimedia channels to enhance diagnosis of leprosy among contacts and in communities? What are the IEC methods, information, education, communication methods, medium of communication to enhance case finding? What is the impact of combined approach of stigma reduction and awareness along with contact tracing? Would provision of skin entity treatment services increase case finding component in existing case detection approaches? That's on that. And on the new partnerships side, we just had a very limited information here, health promotion and marketing comms, and combining skin disease support with new diagnostics if available. Yeah. Thanks.
Oh, wow, short. Thank you so much, Group 4. So at this point, we would like to say thank you for your participation in providing your feedback on the questions. So can you give yourself a hand? So we have a way to clap in Liberia. So Tia will lead that.
I was handing that off to you. Well, I can't be tapping with I'm loud enough. It's okay.
I love you.
So one clap for ourselves. Two claps. Final clap.
Oh, final.
Final two claps.
Thank you, Tia. So we want to say thank you for your time and your participation. We will collect all of the notes from you and we will compile that. We also ask that you network with each other, get each other contacts for future work. And thank you so much. It was wonderful meeting you all. Bye-bye.